Now it is the time for our third and last presentation of this session by Dr. Arif Shaikh. He is Professor of Radiology and Co-Director of Cardiovascular Nuclear Medicine at Temple University. He is board certified in nuclear medicine and nuclear cardiology and has also received board certification in nuclear medicine. He also published papers with PET MRI, including neurology, and participated in cardiac nuclear imaging clinical trials amongst other interests. Sir, kindly come to the stage.
Once again, thank you for the invitation. I thought I'd speak on neurologic nuclear medicine that's not talked about that much. And actually, when I realized this talk was in Faisalabad, it dawned on me what I wanted to talk about. I would dedicate this talk to two very distinguished people, Dr. Ayub Khan Umayya and Dr. Hussain Abdul Dayam, who's my personal mentor. But Dr. Ayub Umayya is from Punjab originally, but he's one of the global giants in neurotrauma and neurosurgery. People might know something called in the West called Umayya shunt. It's actually the Umayya shunt used in chemotherapy and to some extent traumatic injuries and actually normal pressure hydrocephalus and other disorders, where actually we can use it, nuclear medicine, to evaluate potential shunt dysfunction where some radiotracer is injected into the reservoir, because the reservoir basically is created in the cerebrum, and then there's a shunt that goes into the peritoneum or into the atrium because of excess CSF flow. So it can get clogged up, and it's just a simple procedure, although it requires neurosurgical collaboration to access the shunt, inject into it, and just to see if it flows. And this is just an example where it flows, and we want to eventually see it just pool into the peritoneum when it's working properly. So that was one of his many huge contributions to the field. But that as a backdrop, head trauma is a problem, and I will actually be specifically focusing on what is called minor head trauma. It's an underestimated cause of disability and can cause physical cognitive dysfunctions. And actually, it's an unrecognized problem. It has over $25 billion of cost, economic costs involved with it just in the US. And people develop these post-concussive syndromes, which are very subjective. There's no neurological problem. All the lab tests are fine. In fact, a lot of the imaging studies are okay as well. And yet the patient feels something, not quite right. So when we look at traumatic brain injury, we can sort of divide it up into, how does the patient present? Initially, when there is a recognized injury, there's the acute phase. You're going to show up in the emergency room or hospital. And once you recover, usually the recovery is very good, but then you may enter this chronic phase, and that's where they're going to walk into the outpatient clinicians with some sort of a problem. The common causes of TBI is, the first one is usually some sort of military combat exposure, active military combat, but it may not be an active thing. It may be a training exercise with live ammunition or something like that. But sports, American football gets a bad rap for that, but soccer, football, regular soccer actually is associated with many traumatic brain injuries. Partly because you had the ball, people don't realize that is a minor traumatic brain injury, but then there's a lot of collisions that take place as well. Motor vehicle accidents as well. And female and geriatric patients appear to have a little bit more severe problem than their male counterparts with similar injuries. And that may be due to differences in just hormones and other things. So what happens on the microscopic range when we look at, again, minor traumatic brain injuries? Usually what's mentioned is the diffuse axonal injury, where what happens is that the axon starts dysfunctioning, And actually not only causes problems at the site of the injury, but can cause problems in anterograde and retrograde neuronal bodies as in axons as well. Now, other changes can take place, such as microhemorrhage stuff that can be detected by MR. And again, I'm actually going to even step back and say we're not going to look at those as much in this talk. So you can get some amyloid and tau protein detection at that time. But there are sort of some phases we can look at. There's a hyperacute phase within 10 days where a whole host of things takes place. You can get hypermetabolism, you can decrease in cerebral blood flow, and a lot of other ionic instabilities and things like that. And then you can enter this sort of acute to chronic phase 10 to 30 days out, where you may still have altered physiology and altered metabolic instability. And again, I'm leaning against the areas that have like hemorrhages or anything that could be potentially picked up MR. These are physiologic changes that take place even below that level. So this is really minor trauma, but can still be a problem. Now the good thing is that most of this resolves in terms of the patient's post-concussive syndrome symptoms and symptomatology. It resolves within a year. Most of it's fine, but there seems to be a set of patients in whom this is persistent. So looking at it, several people have looked at this issue in the past, and actually Dr. Dayam, one of my mentors, had done a small study at looking at this. And again, people present with a lot of different problems. It can be from headaches, dizziness, memory problems, concentration disorders, sleep disorders, and so on and so forth. And again, all very nonspecific symptoms. And we may ascribe it to some sort of PTSD or some, related to some event that took place. But it's interesting because the CT scan is only abnormal in 30 to 40% of the patients. Whereas PET CT and SPECT CT and SPECT imaging, in fact, is even more positive in like 60 to 80% of patients. So there's a good percentage of patients in whom imaging, traditional imaging is normal, and yet we see physiologic differences. And again, so many of these patients, what happens is they're just returning with like, I just don't feel the same, something feels off. And so it's hard to make that diagnosis of some sort of, this is a result of your trauma, that this is real. And the problem is because sometimes people actually do end up presenting with a real psychiatric disorder as opposed to something related to their trauma, and it's just impossible to make that differentiation, or you get the wrong diagnosis. So again, this is just a normal SPECT brain perfusion imaging study. This there's a little bit of partial voluming effect back here, but it's essentially a normal perfusion pattern. Remember, this is SPECT, not PET, so the resolution is not quite the same. But what to note is that the 100% of uptake is considered to be around in the cerebellum for the most part, and the uptake in the cerebrum is sort of relative to what we see in the cerebellum. So why is it important? Because you can have a decrease in perfusion up to about 45% at rest, in a resting state, and you won't, you'll be fine. You won't feel symptoms or anything like that. And what do I mean in a resting state? Meaning you're just calm, but if you start doing activities or thinking, or then you might, again, that's when you may not feel quite the same. But when you go below 35%, that's when you start having symptoms at rest. It's interesting because in CT scan, if you go below 25% resting perfusion, that's when you might be able to see changes on morphological changes that you can pick up. So with brain perfusion changes, we can notice up to like 10% of change in the amount of uptake. So before it even gets to the CT, and maybe not before they're even having symptoms, we could detect issues with brain changes. Okay, so this is just sort of an example of what other brain abnormalities look like, just so we have a point of reference. Alzheimer's disease, Pick's, and Huntington's. This is important because, again, as I said, patients may be actually, maybe it's an older patient, and instead of traumatic encephalopathy, they may be presenting with the first signs of dementias. And so again, it's you don't want to kind of mix those up if you possibly can. And so looking at these patterns might give you an idea of what may or may not be potentially going on. So in SPECT brain perfusion, Dr. Dayam did do a small study. It was a retrospective analysis of patients that they did serially. And they were able to show that there was changes in SPECT imaging in the traumatic brain injury. So here what we see is frontoparietal lobe right in this area, for example. It's comparatively down compared to the right side of uptake. So here you can see it in the coronal axes, that there's a difference between the opposite lobes of perfusion. But it's important to get the patient at the right time, because if they're within 3 months, you're more likely to pick up issues than they're more than 3 months out from their traumatic brain injury insult. And you can get various abnormalities that are potentially seen. So this is a case, patient had a normal CT, normal brain MRI, and actually what we see is, again, remember, cerebellum is 100%. So if that's 100%, then the rest of the entire cerebrum is globally down. So that's also, by the way, a pattern that we see in major depression. So then we get into neuropsychiatric imaging. But nevertheless, this seemed to be related to the particular injury that this patient had had. So again, brain perfusion abnormalities may be present even if there's no loss of consciousness. So we're talking minor traumatic brain injury, you know. And like I said, just sort of bouncing a soccer ball on your head might trigger it off. We don't know. And so confirmed sensitivity of SPECT brain perfusion shows that it is more sensitive than CT, and that early imaging is better than late imaging. But there can be some significant brain perfusion abnormalities even without loss of consciousness. This is just a graph that actually shows what FDG metabolism might look like in the brain over time. And again, it sort of confirms that idea that early findings are abnormal. Again, in the mild traumatic brain injury. Of course, in the more severe the injury gets, the more derangement that takes place. But in the mild traumatic injury, it's still present. So you get this hyperperfusion, then hypoperfusion, and then eventual normalization of uptake. And these are just 3 different cases where you can see there's left temporal lobe abnormality. In this case, there's a left frontal lobe abnormality, and other frontal lobe abnormalities, again, prominent, and in this case, prominent hypermetabolism that we're seeing as opposed to hypometabolism. Okay, so moving on from the sort of the more acute phase to the more chronic traumatic encephalopathy, again, it's the only real way to diagnose a true traumatic encephalopathy is an autopsy. There's no good in vivo methodologies. And chronic traumatic encephalopathy may be more as a result of repeated injuries. So again, sports usually comes up in that. So there's significantly longer recovery from hypometabolism. There's an increased likelihood of other physiologic problems that take place, delayed recovery of proper blood-brain barrier function. And actually the World Health Organization recognizes that along with neurodegenerative diseases, that traumatic brain injury are actually one of the two top impact diseases worldwide over the next few years to come. So that, we always talk about neurological Alzheimer's disease, but traumatic brain injury is also a fairly prevalent problem. So, and again, in the early stages, you might see affectation of mood, personality disorders, and a lot of times Alzheimer's disease and CTE can look very similar, but they end up getting treated differently in the long run. So it's important, and now especially that we have drugs for Alzheimer's disease to treat people with, it's more important that we get the right disease recognized at the right time. So best management requires early pathology identification. CTE is a brain disease that manifests, again, personality disorders, and you lose critical time if improper treatment or no treatment at all is provided. And so you need to really identify what are the clinical issues and other pathological issues that need to be identified to get better clinical outcomes. This is just a quick graph on what happens on macroscopic problems, again, with different types of injury. Again, if you get a more severe injury, you are going to get atrophy of the brain and other things that take place. And again, but there's also a lot of microscopic stuff that takes place, some of it which is not visible with MR imaging, some of which is. So with repeated injuries, what starts happening is, again, you get this axonal injury and you get neurofibrillary tangles. These tangles are not necessarily the same ones in Alzheimer's disease. There are different types of tangles that take place, and so it could be a little bit difficult to detect with the current tracers that we have. You can get chronic neuroinflammation. Again, you can get this diffuse axonal injury triggered, and a whole bunch of things happen. But the key thing is that there is amyloid and tau protein deposition and alpha-synuclein protein deposition, which is also associated with Parkinson's disease, Lewy body protein. So all of this stuff starts coming in potentially for CTEs. And this is just a quick slide of showing you the different pathologies that may take place if it's a single moderate to severe TBI versus a mild but repetitive TBI that can take place. And again, you can get these pathologies, but you can get other proteins like TGP43 starting to get deposited in this mild repetitive situation. So how does this look with FDG? It looks like there's a good correlation with symptoms, but the problem is that there are no good studies really looking at this with CTE because there's no specific correlation with autopsy findings. And we know that there's sometimes non-specific uptake that also takes place with FDG. So it's still not really clear that FDG is how helpful it is. We know that it does provide some information, but the extent is somewhat still limited. But what about with tau and amyloid? As I mentioned, that the neurofibrillary tangles that we get and the deposition that takes place, well, first of all, the pattern of deposition is different in traumatic injuries versus Alzheimer's, and can almost be in a reverse sequence or in a different sequence that takes place. But unfortunately, a lot of the tracers that we use still have problems with nonspecific uptake, and the problems that a lot of these deposits with CTEs tend to be very small. So even though you have uptake of tracer, you may get partial volume effects. You don't see them very well because of resolution limitations. And again, there's no good control of pathologic studies, so it's of limited utility. And again, the tracers may not pick up the specific tangles that we see with imaging. So this is an example of a patient who's had an MR at the top, FDG, and then PIB, which is an amyloid agent, and then fluorotaucipir, which is a tau agent. And the amyloid and the tau agents don't really show very good deposition, abnormalities here, but the MR seems to show a little bit of a little bit of an atrophy that we see in the frontal lobe area, as well as there's a little bit of a hypometabolism in the FDG in certain areas, but it's sort of non-specific findings as well. So it's not a really great scan, but it's not a normal scan. It's not a normal scan. And that itself, of course, may have some values. Okay, so this is a little bit of a busy side, but there are developments of other agents that can potentially look at the specific types of amyloid and tau that are coming up. There's an old tracer from Napropro, which is known to take up in these areas, but it also gets taken up in traditional tangles as well. So, you know, it's one of the many drugs coming through pipelines to be able to evaluate potential both dementias as well as brain traumatic encephalopathies. This is just a quick different types of the taus and where the tracer actually locates with regards to different pathologies that can be seen on pathologic samples. And again, there's a different patterns that might be seen of what a controlled normal subject should look like, what an Alzheimer's patient may look like, but what a particularly American football player and military personnel may have in terms of abnormalities. And the red, obviously, the areas of abnormalities. So these patterns, for example, what we're seeing with tau pattern deposition are not what we typically see in the Alzheimer's patients. All right, so what are the takeaways from that? So most minor traumatic brain injuries will not have significant sequelae they may have limited symptoms, they get over it. Again, but there are a few of those patients who have chronic neuropsychiatric issues, but that need appropriate diagnostic testing. And there just really aren't any good tracers at that. There's development taking place in nuclear medicine. It seems to be the best hope for coming up with a diagnostic test that can make change the management of these patients. So currently, though, it turns out, despite all these sophisticated tracers we have, brain FDG PET imaging and SPECT imaging still seem to be the ones that provide us the best information. And with that, I thank you for your time.